Thanks very much for your time. So today I'm going to talk about being an infectious disease doctor in intensive care, which at least early in my career was a little bit like being a spy, or as my kids like to call, a ninja is far more exciting than a spy. So when I told my parents I was going to be an intensivist and infectious disease physician, I think that, based on our first speaker, sounds a little bit like an Ebola doctor. So you go and treat people with severe infections as an intensive care doctor. And I had a very interesting experience when I was in Darwin as a registrar. Darwin is a great place to work, but sometimes isn't the best resource place. And a person actually got flown in by the WHO with query hemorrhagic fever. And the guys turned up in those suits and delivered a patient to an isolation room in Darwin. And the isolation room in Darwin had a door, but nothing above the door. So you talked about negative pressure rooms. So it looked like a room, but really it was a door in an open space. And they delivered the patient in that uniform, and then I was given an N95 mask and some gloves and told by the consultant to go and take some blood. And it was at that point I decided I needed to become a consultant very quickly if I was going to stay in things. So hopefully today I'll make equally as much fun and criticise both intensive care and ID. And I want to talk about what the interaction between the two should be, is in some places and should be. So if we think about infectious disease physicians, we have a reputation for being hopefully thoughtful, deep and meaningful, and thinking about patients deeply, thinking of rare diagnoses like eosinophilic meningitis when the patient probably has the flu, thinking that always penicillin can be used for all patients. Why do people need to use more? I had one very sort of prominent and good intensivist in Melbourne once tell me that he always got an infectious diseases consult when he didn't know what was wrong with the patient, not because he liked the antibiotic or advice, but because an infectious disease doctor always did a thorough review and wrote 5 pages in the notes about what's wrong with the patient. And an intensive care doctor would never do that. So I think thorough and thoughtful. An intensive care doctor? So we're not stubborn, we're just always correct. And other people need to learn that. No one else understands what it's like to be an intensive care doctor. It's much harder. Our patients are sicker. No one could possibly understand. The hospital doesn't understand. No one understands. We have a very hard life as intensive care doctors. We all would agree at the ICU conference it's very hard. And we'll hear about that over the conference, I'm sure. So why must it work? And why is it important? And that's what I want to talk about today. So and why does it end up like this? So why does intensive care sometimes behave like this when they're getting advice? And why is sometimes the advice delivered in this way when it could be delivered in a much better way? So why is intensive care important to infectious diseases? Well, that's the infectious disease doctor asleep. So when I started, I was doing mostly infectious diseases, and then I started doing some intensive care. And I remember talking to one of my infectious diseases colleagues who was shocked about how many people in intensive care were working at night time. Because he said in many years of working in infectious diseases, he's not been in the hospital at night time a whole lot. That wasn't really part of the job description. So infectious diseases have a skill set that is not the same as intensive care. I think that the complexity of what we do in intensive care, especially in a more modern intensive care, with the multiple problems, the technical aspects, they're very foreign to an infectious disease doctor, and I do struggle when I switch between the jobs to go back to infectious disease. It's a very different mindset you need to do intensive care and to do it very well. And I think Australian intensive care does do it very well. So infectious disease doctors need intensive care doctors to look after their patients, because we are in infectious diseases caring for patients that do get critically unwell. And hopefully in infectious diseases, pure infectious diseases I guess, in many cases these patients can get better. You know, they've got infections that hopefully will be reversible or treatable, even as we heard with the more severe hemorrhagic fevers. So why is infectious diseases so important to intensive care? Well, it's pretty simple when we just heard about antibiotics and all the things going on. So despite all the headlines and the worry, which we all have about antibiotic resistance, it's estimated that at least 80 million people have been saved by antibiotics in the last 70, 80 years. Far more than any other medical intervention. It's not even close. Surgery could maybe argue similar across the surgical spectrum, but that's about it. It's not even close to the second thing. So in terms of resource and what infectious disease offers and what antibiotics do, it's not even close to anything else in our armamentarium for ICU. And I won't talk too much about this because we just had such a great talk on antibiotic resistance, but the stats I looked up said we came 8th for antibiotic use in the world, which you probably don't get a medal for. 8th is sort of what you give to the last kid in the race, don't you? And you all get a pennant. But it's still pretty bad out of 170 countries. There were 700,000 deaths each year, and over the last couple of years, due to antibiotic resistance that have been directly attributed. And it's thought that number will go up and up and up. And as was mentioned, there's a lot of sensationalism in the headline, but it is increasing very quickly. And this is very similar to a graph from the last talk, just showing that some of the antibiotics that we put a lot of faith in intensive care, such as fluoroquinolones and cephalosporins, their resistance is going up relatively quickly, and as you can see, relatively unabated. And if you see down the bottom, the orange or the yellow sort of one is polymyxins, which are getting increasing use, as was just mentioned in the last talk, and are now starting to show some resistance as well through combination of use in medicine and potentially other uses as well. So, not to quote one of the later speakers who was my consultant earlier in my career, but antibiotics in intensive care, we do tend to go quite hard with antibiotics because our patients are sick. We have one chance. So we use a lot of antibiotics and we use broad antibiotics, and that's not a criticism. We have to use broad antibiotics because we have to treat the patient early with the technology we have at the moment. I'm sure Jeff will talk about that more later on. Well, do we have a space in reducing antibiotics use? Well, without going through 100 studies, there's many, many studies now that look at reducing antibiotic use, and it's safer to stop antibiotics. Most people will know about this study, which was done in New England Journal of Medicine, about reducing antibiotics in surgical patients. Now, this is very relevant to intensive care patients, but doesn't come from the intensive care literature, and is one of the really good studies, I think, over the last few years for antibiotic use, and it's potentially, if we can translate it into practice, drastically reduce the amount of antibiotics used in hospitals where surgical infections are a huge problem. So infectious disease has got a lot to offer in the wider spectrum of stopping antibiotics and reducing antibiotics use in intensive care. A recent paper published in Critical Care Medicine looked at all the things that need to go into antibiotic dosing and prescription in intensive care. And I'll talk about why this is hard for us later on, but there's a lot of things that are a bit more than giving Tazocin for a sick patient, which sometimes we're a little bit guilty of in intensive care. There's many people in this audience who are experts in antimicrobial PK/PD. There's tissue penetration and different drugs. There's adequate dosing. And we just heard about the fact that there might be more antibiotics and new antibiotics on the horizon that we in intensive care won't have the ability to keep up to date with what's needed for our patients. The other thing is it's not going to be intensive care that comes up with magic bullets for infections. It's going to be probably infectious diseases, universities, industry, as we've just heard. There's the increase in antibiotics, and this is a sort of a schematic diagram of a bacteriophage, which people may have heard of, which is a way that's been around for a long, long time, for over 100 years, but a way of attacking bacteria in a different way, a non-antibiotic way, which may become more useful in the future. So just to now take the mickey a bit out of intensive care, so do we take this seriously? I think it would be hard to argue that antibiotics aren't important, and I'll talk more about that in the future. It'd be hard to say that they're not. There is some difficulty in prescribing. So do we take it seriously in ICU? So this is a major international conference. Don't worry, George, it's not this conference. That recently, this is the number of presentations about antibiotics over 2 days. There was 4. And remember, I'm from the Alfred. So there was 10 presentations, though, on ECMO. So 4 talks on antibiotics, 10 on ECMO over a 2-day period. This is, if you look at the number of patients admitted to hospitals in intensive care in Australia over the last year, that's the number of patients that get antibiotics. It's probably about 200 that get ECMO. And, I'm from the Alfred, we take ECMO very seriously. Many of those patients will die as good as we try and do it. So it does seem a little bit out of whack that that's our sense. Are we taking it seriously? Well, maybe it's part of the curriculum. There were some talks before about education and what happens in ICU. So this was the exam a year or so ago. There was 5 questions that related to ID. Good questions, needle stick injuries, what about a patient with HIV? Sort of a couple of governance questions. What to do with a sick kid. They always check whether adult intensivists know exactly what a kid is. It's not usually a hard question. It's usually like call somebody is the answer you need to come up with. And then there was one question which was obviously very relevant. Discuss the factors in choice of antimicrobial agents in a critically ill septic patients. And I'm always in awe of our trainees doing the exam. They're very clever. They're incredibly motivated. It's a very hard exam. So the general summary from the examiners you can read at the bottom. So the worst question from the exam was the one you look at and say, do we have a way of choosing what antibiotics we would give a critically ill patient? Now that's a bit cheeky and a bit harsh, but I guess it does show that I'm not sure that intensive care is taking the antibiotic side of our dosing and selection as seriously as it should. So with great power comes great responsibility, and antibiotics is a great power, as we heard from the previous talks. Does anyone know which great philosopher said this statement? Spider-Man. Very important philosopher, Spider-Man. They make a movie every year, so it's very important. That's why they wouldn't make a movie every 6 months with him in the title. So I think it is important. We do have it is a weird sense with antibiotics. It's one of the. It's been said before. you're treating the patient and the next patient and the next patient and the next patient with that one dose of antibiotics. And we've all heard about units around the country that have had big problems with antibiotic resistance, and we all have them to some degree in our units, and we have to take some responsibility for that. So maybe we could talk about sepsis in ICU and say, well, maybe I'm being a bit harsh. We do know about sepsis in ICU, and an infectious disease doctor is not going to help with that. We're the world experts in sepsis. So ICU worked out the definition for sepsis, and it left infection as infection. So if you read the definition, it's a very well thought out definition, but to me it's a bit of a description of a sick person. So life-threatening organ dysfunction is good, and the dysregulated host response is, I think, a very clever way of describing sepsis. That's fair enough. But there is no attempt in the definition to describe what an infection is, which makes it very challenging to have a definition for a condition that we all know is very serious, but we've made no real attempt to define what is the thing causing the problem, which is infection. Otherwise, you could make an argument that life-threatening organ dysfunction is all of ICU, and a dysregulated host response is probably many of the patients in ICU, sepsis or no sepsis. It would be a very good argument to make. So slightly frustrating. On the positive side, it was ICU that has made an attempt to at least attack this problem, because I think the rest of the world is ignoring the sepsis problem. And to be fair, there was a paper published in JAMA about 2 or 3 years ago that showed that sepsis mortality in Australian and New Zealand intensive care was declining dramatically. So over a sort of 15-year or 13-year period, sepsis mortality had gone down pretty consistently and amazingly, really, when you think about 35% to 20%. But there is a small issue with this. If you look at the ARISE data and other data, and people will probably know about ARISE, which was the early goal-directed therapy study, if you had a Mortality score of greater than 25, you still had a mortality of 45%. Which, if you just imagine your intensive care, if you look at those physiological variables, that gives you an Apache score of 25. That doesn't look, it looks sick, obviously. He's going to come to intensive care, but that's pretty amazing when you say that guy's got a 50-50 chance of dying in every intensive care in Australia. So I don't think we've come quite as far as maybe we think. We have done a lot of work in intensive care and the emergency departments about delivery of sepsis, and of antibiotics for sepsis, and there is controversy over this data. I would be a believer of. If I'm in emergency and I want antibiotic, if I'm sick, can you please give me antibiotics quickly? That would seem to be the best data we've got. But if you look now if you give antibiotics in the first hour, there's many retrospective studies, admittedly, that admit that early antibiotics is good for mortality. As I said, a little bit controversial in some of the more recent editorials in particular, but I think the data is relatively clear that a package of care in emergency for sepsis that includes antibiotics is very helpful to people. And I think that's useful, as again, this study, the line is the risk-adjusted risk of death, depending on the delay of antibiotics in New York hospitals. And I think that's useful for people to know, because that really has been driven by, despite criticising the definition and the intensive care work in sepsis, that's driven this practice, and it's driven it for emergency medicine as well, the recognition of sepsis. So from this, you could sort of acquire that what really works in sepsis, well, antibiotics probably works. You could make an argument, and it's been said with that reduction in sepsis mortality for ICU patients overall, is really an improvement of general ICU care. We've just got better at doing things. We pick up patients earlier. We have bigger intensive care, so people get into intensive care earlier, and we do good therapy. And we probably have good source control, although the evidence for that is not there, but anecdotally from all of us, we know that good source control is important. So that's okay. We could say, oh, well, in ICU we've got lots of other things that work for sepsis and infectious disease. We've thought of all these things, and they're really good. They all work really well, except none of them work anymore. So these are all things that did work. So activated protein C, well, it did work if you go by evidence, and then it didn't work. Gastric tonometry, I don't know about that. Gamma globulins, maybe it does work, but the latest trials didn't. Selective decontamination of the digestive tract, well, it does work in some countries, but we don't do it in Australia because we don't do it. We tried altered blood pressure, that didn't work. We tried early goal-directed therapy and then spent $20 million proving that it doesn't work, when it did work. We tried old versus new blood and then more versus less blood, and none of them worked. What we do know is we do good general intensive care, but we haven't come up with a magic bullet. And I don't think in intensive care we're really close to getting there from that point of view. So what is the problem with intensive care and infectious disease? Why, when I was asked at this talk, why was the topic given to me is there's a problem? There's a fight between ID and ICU. What is the problem? Why, when you've got a very complicated area like infectious diseases, why is intensive care not embracing it more? And why can't we do a bit better and get beyond early antibiotics and some of the other things in sepsis in particular? Well, one thing, and I think for anyone who works in intensive care, and this is criticising my other specialty now, infectious disease, I think the thing is the quality from infectious diseases. We need to demand quality from those units and from our teams in infectious diseases. We need to demand that the service is comprehensive, useful, available, listen and educate. And I was going to do a survey of this from people's phones, but then I realised I know where lots of people work, so that's probably not a good idea. I don't know how many people get infectious diseases consultant level advice, either microbiological or infectious disease, in their unit every day. So not many in Australia. It's good. Some do and some don't, but I would want it if I was the patient. How many have access to therapeutic drug monitoring? And I don't mean gentamicin and vancomycin. Gentamicin and vancomycin was available when I was an intern and a medical student, so that's 25-year-old technology. That doesn't really count as advanced therapeutic drug monitoring. How many people have local antibiograms? How many people have access to infection prevention at a 24-hour level, so at 24-hour timing, so they can work things out, as was mentioned before, about risk for travellers and things like that? And how many people have guidelines that are implemented based on local antibiograms and not just therapeutic guidelines? Not many in Australia when you look at the data. This is an example of an antibiogram from our hospital, and how many people working in intensive care would have that presented to them very regularly, saying what is the latest blood culture results or sputum results, and what's the risk of this patient's getting this antibiotic, of the blood of the infection being resistant. So the second problem is people don't believe that works. Is it really that important? Can't we just give Tazocin for everything? And most people know that in the last, as an example, Augmentin has come out in the last couple of weeks in Australia, or last couple of months in Australia, and everyone thought that would be great. So if you don't liaise with infectious diseases, you wouldn't know that 20% of E. coli in Australia is resistant to Augmentin. So there's been some talk that many intensive cares will switch to Augmentin. That may work in some intensive cares and it may not, but it may be a big mistake. But just looking at that, does it work? This is some stuff from ANZICS that's so far unpublished, but if you have 175 sites contribute to ANZICS, and as part of that, for anyone who's seen the reports, you get like a quality report of whether you do things that have been judged to maybe improve the quality of intensive care. So that's things such as, do you have process checklists, as you can see on the far right? Do you get an infectious disease specialist to come around? Do you get a pharmacist? It's pretty coarse data. It doesn't go into how many times a day do they come, what do you do. As part of that, you can see is antibiogram on the far left. And as far right is the antibiotic stewardship. So you can see many, many units now have some sort of antibiotic stewardship. Again, it doesn't tell you how good that is, but it is something. And you can see it obviously doesn't correlate with infectious disease specialists, so it doesn't necessarily mean that it's an specialist level of advice. But the antibiogram is much lower. So if you look at things that have been shown to make a difference for mortality for units, with hundreds of thousands of patients, the only one that's been shown to make a difference probably is the use of antibiograms for intensive care units. So that, which makes perfect sense when you think about it, even though it's easy to criticise data that's from registries and big organisations such as this, is because if you don't know what antibiogram in your unit is, how would you know whether you're giving the right antibiotic to these patients when we talk about early antibiotics being important? So the last thing I want to talk about was whoever invented, and I won't again criticise, whoever said that stewardship is the word that should be used to describe infectious diseases working on the wards or in ICU is clearly stupid. Because if you tell ICU that the stewardship job is to supervise or take care of something else, the intensive care people will get grumpy. I don't think intensive care like being supervised by anybody, let alone as a general, and hence the grumpy person on the left. It's not really something that intensive care in Australia takes great pride in looking after their patients and caring for their patients. So stewardship is probably not potentially the best word for describing, and maybe that's where the problem has begun. So I would argue that actually it's much more of a synergistic relationship between ID and ICU. And I've got two young boys, and I can just imagine them doing this at a computer game. It's something that sometimes ICU will need ID, and sometimes ID will need ICU. And at the moment, I think the model of stewardship is probably not greatly delivered by ID in many centres because of funding and other reasons that are valid. But I think ICU probably has to accept that it's becoming such complex as an area that we are struggling in that regard. And so finally, I'd just like to point out, remember from the one thing from this talk with antibiotics, if you can remember the great philosopher Spider-Man, thank you, and remember the great responsibility. Thanks very much.